Thank you, Dr. Sarita, for having me here. So, and this is a topic with plethora of questions, but very few answers. But I'll try to answer, taking few cases into consideration. And these are the options we have for a patient in cardiogenic shock, IABP, Impella family, or tandem heart family, and ECMO, and also CentriMag. But one problem though, tandem family is not available in our country. So, and CentriMag, yes, it is available in very few centers. In fact, even we don't have in our center. But that's also a good device, often for open implantation, but it can be also used as a ECMO equivalent when possible. And the quantum of support with these devices, you can see this is a quantum of support we get with the tandem heart. It's lesser, sorry. So, otherwise, all other three devices gives you similar kind of support. And what's an ideal MCS device? Of course, there is no ideal device available, but one which is easy to implant, easy to maintain, and easy to remove, and provides a good hemodynamic support without any need for LV unloading, and which is durable as well as biocompatible and cost effective. So, and there is no answer as of now, and there is no ideal MCS device. You have to choose between what is available for you. But these are the factors which influence decision making in labs. One is lack of robust evidence for any of these devices, and also there is conflicting evidence on some devices, and the most important thing is availability of human resources in the hospital, which can take care of this device management as well as management of these patients. That is shock teams. And next is availability of devices and preference of centers as well as experience of people. And this is one thing which is quite consistent in terms of data. If there are shock teams, that will change the outcomes of patients, these patients. It could be with a drug or it could be with a device. So, but the presence of shock teams is the most important thing which changes outcomes. And it is very important to balance the risk versus benefit in these cases while moving on to a device, because these devices can spoil the outcomes because of their complications like hemorrhage, infection, hemolysis, limb ischemia, and also embolic episodes. And these are the factors you have to consider while choosing device. Anyway, I'll take you through a few cases. You can see this is a young male, 26 years. You can see the ECG, came with an acute antral MI, and in ER, he crashed. And almost 3 episodes of VT, pulseless VT, cardioverted, but not maintaining hemodynamics, so repeated shocks. So that's when, and we checked for his, lactates, already lactates were high, and he was on significant dose of inotropes. And what's the choice now? So it's an acute MI, almost like shock, C to D stage, and unstable rhythm. So of course, IABPs, it doesn't give, such good support, and we have now data available which is against this device usage. Though it is the commonest device used across the world, in fact even in the West. And when the rhythm is not stable, again, Impellas may not be a great device in such patients. So the best is have a VA ECMO. And so we went ahead, so while continuing CPR with the CPR device, we went ahead and commissioned the VA ECMO on the patient, and then checked angio. You can see there is a total occlusion, and then we opened the LAD, and subsequently we continued VA ECMO for this patient. Of course, for all patients we use distal perfusion. So distal limb perfusion is created, And you can see this was the echo at the time of admission, and this was the echo after 3 days of procedure. So there is a huge improvement, and this is a simple guide when you want to explant device for these patients. When to explant, no or minimal inotropes, reversal of metabolic parameters, and LV function is another guide in these patients. So another patient, 34-year-old, came with a VT storm. He was throwing VT in emergency department, and no one has a clue what is the reason. And patient was apparently normal 30 minutes before he presented to the hospital. You can see his heart rate high and BP is borderline, and lactates are already high, 6.7. And this was the ECG. You can see funny rhythms at different points of time, 2 ECGs. And this was the echo. So that's that baffled all of us, because his LV is perfectly, seems okay. There is not an issue in LV. So we thought of, looking at, since his sensorium is very poor, so thought of doing imaging, but in the course, he crashed, VFs, defibrillation, and then we took patient directly to cath lab instead of imaging, and we did an angio that further baffled us because angio was normal. So, and then what to do? So the only thing we can do in this patient is just to stabilize, his perfusion and his metabolic shock. That's what we thought, because we were not aware of the reason what he was going through. And this won't give you sufficient support, and this doesn't work because patient is throwing into repeated VFs and VTs, and we just went ahead and positioned VA ECMO. And to our surprise, after VA ECMO, this was his ECG. So he dramatically improved. Only one finding in him was his potassium was very low, that is 1.9, but we don't have a clue why it was low. So later rhythm stabilized, we continued VA ECMO for 48 hours despite rhythm stabilization, and all metabolic parameters settled and no inotrope requirement. Then we removed VA ECMO, and later, 2 days later, patient revealed what he has done. Basically, he took caffeine overdosage. So he took almost like 100 tablets of caffeine, and no one knows what is going on. So that's a reason for his VT storm. And another case of ACS with cardiogenic shock, and this patient, a cardiomyopathy, ischemic cardiomyopathy, presented with ACS and with decompensation. So in all such patients, and there are no apparent ECG changes, you can see this is a LV. So I'll just take 2 minutes more. So this was his LV, and this was his coronary angio, total occlusion of LID, total occlusion of RCA. So in such patients with the cardiogenic shock, already stage C, and on inotrope support, needs revascularization and turned down by surgeon, and these are the risk scores. So what device we can use? Of course, again, this may not work, because if this patient really needs, in the course of procedure, this won't really support anything. So out of other 2 devices, the most important thing is RV function, because often in these patients with chronic heart failure, even RV can be a problem. So, and you can see almost 50% of patients, even RV is dysfunctional. So assessment of RV is crucial. Once you put Impella, your RV function will further come down because of the septal movement and septal pull towards LV. And all these assessments helps you in understanding RV function. And best is the PAPI. Take PAPI, pulmonary artery pulsatility index, before you jump onto device. And if the PAPI is good, then it is isolated, LV dysfunction. That's where, you can use only Impella. So since this is one algorithm which we can use, we used Impella and we revascularized. You can see this is RCA, and this is LAD, which we opened. And subsequently, we weaned off after 12 hours. Since he was in shock, we took more time to wean off. And this is the protocol which we used for this patient. And another patient, similar cardiogenic shock, triple vessel disease. But this patient, as the shock was not responding to conventional strategy, so intensivist already moved him on to IABP. So IABP was inserted in the middle of night just to stabilize his shock. And in the morning, we took the patient for angio, and you can see again the triple vessel disease with RCA total occlusion. And it's a poor LV. So how to go about, whether to continue IABP and do intervention, or you want to use another MCS for good support. So we had a discussion, and this patient is basically a father of our VA ECMO in charge. So, and we had a discussion, and we decided to move on to VA ECMO, because it may not support IABP if really I need during procedure. So, and access management is very important. Already IABP is there from left groin. So we used right groin for VA ECMO, and this is when we can use this technique. So you can do PCI through the VA ECMO sheath instead of taking one more axis. That is what we did, and this is a technique which can be used in such patients. So we continued VA ECMO along with IABP, probably thinking requirement of afterload for this patient after procedure. You can see, in fact, his LV gone bad after procedure. So, and we felt that decision of VA ECMO was correct, just to tide over procedure. But this is what happened after that. So this is very important. These devices can give you a lot of issues. Patient went into limb ischemia on the side of VA ECMO. And again, it is only distal ischemia, mostly because of the distal perfusion. He also developed a GI bleed on day 3. And finally, we lost the patient despite everything. So to conclude, a structured cardiogenic shock response team is very important, to change outcomes, not just the devices and medicines. And consider MCS if shock is progressive despite conventional therapies. And assessment of RV function is very important to decide the type of device. And availability and also affordability also plays a key role. And early detection and management of complications is key again. And of course, we need to learn more on these devices, when to choose, when to shift patient under device, and right patient, right time, and how to, all that stuff. Thank you.
Thank you, Sharath. It was an excellent talk. You really showed nicely which device is apt to do what support. And I think we have to see this together with the next talk. But I want to ask if the panel has to pose a question to Sharath.
Early introduction of MCS is better. So we have to decide earlier. Just in the third case, you kept overnight in the ABP, and then you went ahead with the Impel Isinat.
Yeah.
So instead...
No, IABP plus VA ECMO, yes.
VA ECMO, yes. So it is better to go and decide early and do the procedure early.
Yeah.
That is a strategy as far as MCS is concerned, is it not?
Yeah.
Do you accept with me?
Yeah, see, the reason why I showed third case is often when these patients present in middle of the night, so that is when, initiating VA ECMO, Impella becomes, very difficult. Even in my center, despite, we have all the teams, so it becomes very difficult. So that's when sometimes it so happens that, they put an IABP to just tide over the crisis and manage, shock, not to let the patient deteriorate further. And then, we have to, these are the real world problems. So, and morning we had to take the case up for procedure. And that's when I have to decide between whether to switch to another MCS or, continue both and do procedure. So there are some choices to make. I mean, I have to make some choices. Yes, it is difficult.
Not a question, but a comment. Very good presentation. This idea of having a shock team in place in high volume centers make a real difference, I guess. It's a very good idea. We have PE teams, we have, I mean, these are all kind of structured teams. In big setups, I think having a shock team in place, we don't have any in Pune, I mean.
Yeah, and
in-
everybody does one job at a time. And
Perfusionist,
yeah, I agree.
you know, having an
Yeah.
intensivist on board, I
that's a
mean,
good- yeah.
alerting them, like VT storms.
Yeah, that-
If you have a team in place, I mean, it's a fabulous idea.
And I just would like to ask one question. What is your crossover time? If patient is not responding with whatever mechanical circulatory support you had done, then how long you will wait and what is the crossover time?
So in our center, we assess patient every 4 hours.
Okay.
And we analyze data. Shock team will analyze data, and our cardiac intensivist is the key in the team. So every 4 hours, 4 to 6 hours, we analyze data, and if patient is not responding and deteriorating despite whatever stuff we are doing, then we'll move on to the MCS device. Yeah.
Good. Yeah. Thank you. Thank you for your excellent talk. And